Hello, everyone. Good afternoon. Thank you for joining us today at the CAQH Core Town Hall. Quick run through of our agenda. We'll get started with an overview of CAQH Core and our mission and vision, and then we'll jump into a spotlight on our new CAQH Core operating rules. After that, staff will give us an update on core certification and recertification, an update on our ROI measurement initiative, including pilots to track the impact of new and existing operating rules. From there, we'll walk through our efforts related to the No Surprises Act, as well as introduce our upcoming focus group. We want this to be as interactive as possible, so we'll end the session with a panel and Q&A with core staff. Some logistics for today's session. You can download the presentation slides now from the handout section of the GoToWebinar menu. You'll also be able to download the slides and recording on our website after the webinar. A copy of the slides and the recording will be emailed to all attendees and registrants in the next 1 to 2 business days. And please feel free to forward that email to anyone who's interested within your organization. Questions can be submitted at any time using the questions panel on the GoToWebinar dashboard, and we'll either address your question immediately or respond to it during our Q&A session at the very end. So with that, I will turn things over to Erin Weber, Vice President of CAQH Core.
Great, thanks Daphne, and thanks everyone for joining us today. I know we had a high number of registrations. So I'm going to provide a little bit of background because I know we always have some new folks join us on these town hall calls around course history and how we got to where we are today. So many of you know about 20 years ago, HIPAA was passed and the industry began implementing electronic standards to support the billing and payment systems in healthcare and to enable providers and health plans to exchange that data in a consistent and electronic way. What happened was that there was need within the industry, quickly identified, for some additional business rules to support those standards. And so CAQH Core was founded by the industry to develop those operating rules or business rules in much the same way that occurs within the financial services industry, transportation, and other industries that are exchanging electronic data. Our mission is to support standards, accelerate interoperability, and align administrative and clinical activities. Operating rules never repeat or conflict with what is required by a standard. They simply build on the standard itself through infrastructure requirements around things like response time and additional data content within those standards. In 2012, CAQH Core was designated as the National Operating Rule Authoring Entity for the HIPAA transactions by the Secretary of HHS. And several sets of our operating rules are now federally mandated. We have a multi-stakeholder participation and really see our role not just to convene the industry to develop and vet operating rule requirements, but also to educate the industry around the role of operating rules and standards, to test and certify and drive adoption through our certification programs and our measurement initiatives, which you'll hear more about in a few minutes. And then we are continuously identifying industry needs in areas where there might be need for greater definition and business rules to support industry data exchange. Next slide. We have about 110 organizations that participate with CAQH Core, representing a very wide range of stakeholders, including health plans representing about 75% of insured lives across the United States. This is really important to the work that we do because the operating rules apply to all HIPAA covered entities or can be implemented by all HIPAA covered entities. And so we need your organization and your voice to be at the table to make sure that the rules make sense for your stakeholder type. You know, I think back to some of the discussions we've had in our subgroups and work groups over the years, and if 1 or 2 stakeholder groups were missing from that discussion, we might not have had as robust requirements as ultimately came out in the operating rules. So really encourage you, if your organization is not on this list, to reach out to us and talk about ways in which you can get involved in more of our day-to-day activities within CAQH Core. And finally, on the next slide, I just want to highlight the operating rules themselves. Core now has 8 sets of operating rules, really spanning the entire healthcare revenue cycle, starting at eligibility and determining whether a patient has coverage and doing that electronically, all the way through payment, including enrollment and premium payment between a health plan and an employer organization, for example. 3 of these operating rule sets are federally mandated: the eligibility and benefits rules, the claim status rules, and the payment and remittance rules. And I'll highlight another set of rules on here, and that is our attributed patient roster rule set. One of the things our board has really identified over the past couple of years is the role that operating rules can play also related to value-based payments and the administrative burden of a wide variety of value-based arrangements and administrative needs to support those programs across the industry. So that's an area where we'll be doing some environmental scanning and focus work in 2022. I am now going to turn it over to my colleague Bob Bowman, who's going to talk about some of our new operating rules that were just published over this past year. And they really complete the set of work that we have done to date related to prior authorizations and some key updates to existing operating rules. Bob?
Great, thanks, Erin. If we move to the next slide, we can really look at, as Erin mentioned, the work that we do really builds off of our mission and vision. We are an organization, coalition of all of our participating organizations that really works diligently to not only create operating rules to meet needs in the market, but also update rules as they've become not necessarily outdated, but as more business types of processes have been added and layered on to our busy lives already within healthcare itself to meet those new and emerging needs. So we do help align the different standards that are developed with the technology and with business practices and business processes to ensure that we're meeting the expectations for that data exchange, right? If providers need data and health plans house it, how do we get that provider to the data when they, how do we get that data to the providers when they need it most? Usually when they're caring for patients. Another key component, as Erin mentioned, is that we need to expand our pilot and measurement initiatives to ensure that we're tracking with the industry when it comes to return on investments and to ensure that we're also engaging with our industry partners. So as Erin mentioned, there's that give and take with our participating organization. We really look to them to help drive and identify the need. We filled our work groups and our task groups with those folks to help host those discussions. And then we develop the rules and the requirements. And as you see on the next slide, last year was really busy. We put together 2 different sets of new operating rules, updated 2 other sets of operating rules. And so what that means is that, as you see here, we really looked at attachments, both to support the prior authorization use case as well as the claims use case. So we built up sets of requirements for infrastructure for both, as well as data content for both. We'll look at a little more in depth on what those requirements are in just a minute. But as you can imagine, you have to lay the tracks down between the provider and the health plan, identify the data needs, and ensure that the provider can submit the data and or receive the data from the health plan to support those use cases. Usually to remove a pend, right? A prior authorization has been pended, a claim has been pended, the provider's initiating the submission of an attachment to remove that pend and get the PA approved or get the claim approved and move it down to the next step of the process of the revenue cycle. We've also updated, key here is our eligibility and benefits data content rule. The task group really worked really diligently on updating those requirements and making sure that we're meeting the provider needs when it comes to the benefit information on those members that they're servicing. And last but not least, we've also updated our infrastructure rules for our system availability requirement. Many of our rules do have system availability requirements, and we've modernized and caught up with the rest of the industry really when it comes to how often that system needs to be up so providers can continue the care delivery in a more modern contemporary 24/7 model that is taking place in the industry. Now, moving on into some of the detail of the requirements that we developed over the last over the last year and into this year. Beginning with our prior authorization use case, we've developed very specific sets of requirements for both infrastructure, data content to support various payload formats. So this includes both the X12-275 as well as non-X12-275 payloads. So if your system today, your EHR, your practice management system, your web portal that you're hosting or using, if you are submitting transactions using the HL7C CDA, if you're using FHIR, a PDF, a TIFF, a GIF, a GIF, however you're submitting that data today, the infrastructure requirements and the data content role requirements can support further development to help ease the administrative burden, meaning the manual processes used today, to submit those transactions and those pieces of data to support prior authorization. So we've come up with sets of infrastructure requirements that include a standard method of acknowledging the receipt of the information. So you submitted a scan, the health plan would acknowledge receipt of that scan. So it's not in some black hole and you don't know if the health plan has received it or not. There are certain requirements for the size of the data that's being submitted. There are standard methods and response times, so you ensure that the acknowledgement comes in, you ensure that the time frame, if it's in real time or batch, you understand exactly what that time frame is in processing the receipt of that data. As mentioned earlier, we have system availability requirements and the companion guide format requirements to ensure that as those software vendors and clearinghouses support these interactions, they can build the systems and applications to ensure that that connection is there, the data is there, and is passing between any sort of intermediary between the provider and the health plan. And last but not least, really key here is the reassociation requirement and consistent reference data for the data content requirements. Oftentimes, the interactions for a prior authorization and the attachment that supports the prior authorization, it's a bifurcated process. The provider submits the PA one day, it pens, then they realize that they need to submit an attachment, or they're using two different systems. The PA's inquiry may come from their practice management software, but to support and send the attachment, it has to come out of their EHR. So that bifurcated process, either through systems or by time, reassociation of those two transactions or interactions or inquiries needs to take place. So we've identified a set of data to use both by the health provider and the health plan to reassociate those two transactions back together, either at the provider's location or at the health plan's location, to ensure reassociation takes place. The health plan can key those back together, kind of stitch them back together, can process the prior authorization more completely, and return a response more expeditiously back to the provider. So as you can imagine, if we're talking about attachment rules and requirements for prior authorization, quite a few of them are also similar to what we would require for claims, and that you'll find on our next slide. We do, again, extend those requirements for the X12 standard transaction as well as non-X12 standard transactions. We also have very specific infrastructure requirements for claims. A particular one here that was really key with our participating organizations was to establish electronic policy access requirements. What do we mean by that? What we mean is that health plans have to publish electronically what the requirements are for each of their claim types of pens that they might publish that requires an attachment to actually be submitted. So you as a provider will be able to basically use the internet to identify what those attachment requirements are, so you know before you submit the claim what those policies are, and you can submit the attachment with the claim. Again, the methods and modes and means might be a little different and vary because of the system that you might be using, the vendor that's supporting you, the clearinghouse, but at least you have the access that, yes, this particular claim will always require this image or this scan to go with it to ensure that it doesn't pend right away. It helps expedite that process. We also set requirements that you may have to, as a provider, submit multiple scans to support a particular claim. So we also allow the health plans to build systems to support multiple electronic attachments to support that single claim. so it doesn't pend. You submit an attachment, it removes the pend, then it goes through that pig in a python, down to the next pend, and then you get another notification that you have to send another attachment, and just it delays that payment process and the expedited processing of that claim. This way, all of that information can be supported in one fell swoop, one go. So there's not that back and forth and back and forth. And lastly, there's also a data content requirements for our claims attachment, ensuring that, again, we have reassociation type requirements between the transactions, between the submission of a claim and the submission of the attachment, as well as ensuring that health plans use the most appropriate LOINC codes to request the most specific additional information. Again, as we see, there is a continued migration within the industry to look at both administrative and clinical information and data sets to ensure that we're all speaking the same language. So if you're on the health administration side or healthcare delivery versus either one of those sides of the coin, as we get more used to using the same data sets and the same vocabulary, it makes it much easier to process these types of transactions. So as you can see on the next slide, there are some key benefits for supporting the attachment rules. There's the convergence of the clinical administrative data, as I mentioned, using specific code sets to help move the data and understand the data requirements. It helps everyone through that process. Also, key infrastructure requirements. Again, those train tracks have to be laid to ensure the provider can submit the transactions, receive acknowledgements, and understand exactly what those requirements are. We've helped simplify the reassociation of both claims and prior authorization with these sets of data that helps prevent any sort of manual intervention that might have to take place to identify, oh, this attachment came in from this provider, but I'm not sure which patient it goes to or which claim it goes to or which pend on the prior authorization it goes to. How do we do this? Well, the reassociation data sets really help identify that information. And lastly, all of this information, as we try to simplify the process of submitting an attachment to support a prior authorization or a claim, leads to quicker coverage decisions to support the patient care and faster payment of the claims. We're trying to alleviate that burden on care delivery as well as the payment processing or prior authorization adjudication that takes place between that provider and the health plan. Next topic would be the updates that we've made to our eligibility and benefit data content rules. As you can imagine, this was also quite a robust discussion that we had with our core participating organizations. Our core board asked us to review the eligibility information and see if there's anything there, because one thing that providers and health plans can probably agree on is that as they update eligibility information within their systems, providers submit an eligibility inquiry, but often also pick up the phone just to validate it. So you see something as a provider in your practice management software, and you don't feel comfortable with that actual response, so you pick up the phone and dial in and try to just make sure you have a coordination or coordinated response between what appears on screen and what appears on the phone. What we've done, we've heard and listened to both our board as well as our participating organizations and updated our eligibility and benefit data content rule, which is the first time since 2008 that we reviewed the rule and tried to meet business needs where they are. So there are 6 different areas that were updated. This includes our updates to support eligibility inquiries using procedure codes. This could be CPT codes, HCPCS codes, REF codes, mostly around these particular topics of physical therapy, occupational therapy, surgery, and imaging. In the future, as health plans build out this capability, providers will be able to submit a CPT or HCPCS code and receive direct information about the member benefits on these particular services. We've also added 71 new discretionary STC codes and 55 new mandatory STC codes, moving our total from 55 to 178 core required STC codes. Not the entire set, but pretty close, so every health plan will be able to support an explicit inquiry for a specific specialty. So if you are a specialist provider or healthcare deliverer, you'll be able to request benefits about that member specific to that specialty. Lastly, for this slide, we've also made sure that we're meeting with and exceeding CMS's place of service codes for professional healthcare claims. It's code 02 and 010. and 10, to help communicate the needs for telemedicine. Does this particular service allow for telemedicine delivery or not, right? That's important, especially as we move through the pandemic. So we've included this in this set of operating rules requirements as well to ensure that benefits that have telemedicine limitations or non-limitations that can be returned back to the providers so they can understand if this particular care can be delivered through telemedicine. 3 more areas of update are on the next slide, and that includes remaining coverage benefits. These are where oftentimes you may have a limit or to the number of visits that are specific. So maybe it's occupational therapy, chiropractic care. There may be a limit to the number of visits for a planned year or for an episode of care. Oftentimes providers would only get a count. This particular member has 10 visits. What visit are we on? Maybe there was a break in care. Maybe you have to move to a new provider to deliver that care. The first provider delivered 5, but you only see 10. So you would have service that 6th one, and then it would be denied. This would ensure that the remaining numbers are returned, not just how many for the benefit, but how many are left for that particular member for that particular time period. We've also ensured tiered benefits were covered in our operating rule update. And this ensures that if there are tiered benefits for that particular member, that the information can be returned. This could be include anything around coverage status, patient's care in and out network determination, benefit coverage, also communicates the status in the network is in or out or exclusive networks. So ensures that if there are these variables that take place through the care delivery and through time for that particular patient member, that the provider has that information electronically and immediately. And last but not least, another key component that the task group wanted to ensure was included was requiring the communication if a prior authorization or certification is required for the core required services or procedure codes. Again, if a service is returned on that particular member, this would ensure that that indicator is turned on for that particular service. So the provider knows immediately that, yes, this particular service will require a prior authorization. They can key that process off if that's how the care delivery should take place next. So it's really helpful for the providers to know, yes, this particular service will require a PA. They know that if they're going to provide this service, they can issue the PA right there when the patient's in the office and take care of that immediately. It's really, really helpful. Another and probably one of the most contentious debates that we had over the last year is on the next slide. And this was updating, I apologize. Some of the key benefits here were reducing the time and effort and spent verifying the information that is coming in from the health plan. So maybe you won't have to pick up the phone just to validate everything that's coming in on the system, but to understand that that data is becoming more and more specific and more granular, so you understand exactly what those benefits are as they relate to telemedicine, prior authorizations, remaining benefits, procedure level information going out all the way to the procedure level. You understand that particular procedure code does require a PA or does not require a PA. And you find that out on the eligibility transaction right away when the patient's there in real time. And last but not least, all of this is meant to help have more accurate pricing and billing practices from the provider. Cleaner claims can come in. Providers know what to expect. They understand what might actually happen with that claim because they have the information on the eligibility transaction, trying to clean up that information as it comes in. And then again, is one of the most contentious debates that we had in a long time here at CAQH Co-Returner participating organizations was the update that we moved towards this last year for moving from an 86 system availability per calendar week to a 90%. As you can imagine, much debate because this actually looks at the technical capabilities of the systems. So as you fire off a transaction, be it a claim, an eligibility transaction, a claim status transaction from your PMS system into your clearinghouse and then onto a health plan or directly to your health plan, that system needs to be up and available, ready to go to receive that inquiry, receive that transaction, and respond to it. And that is systematic changes and updates that have to take place to make sure that we meet that 86% goal. Now we bump that up to 90%. So this was, as you can imagine, quite contentious, but we really came to consensus because this is something that the participating organizations at CORE really felt strongly about. We did add a new requirement, basically to ensure that if there are larger systems that need to take larger chunks of downtime to make more migratory more complex system updates, those can take place on a quarterly basis. So we reduced the downtime overall by 364 hours annually to ensure that that system is ready and available to go when the provider needs it. Some of the benefits, as you can imagine, in updating our system availability rule requirements are found on the next slide, where it really highlights that we're aligning with today's business and business needs, trying to make it a 24/7 real-time type of experience for providers and health plans as they develop and mitigate their systems and build new systems to support the transactions. It allows for longer, less frequent periods of downtime. So we're trying to push all of the availability of the data out to be more frequently for providers to use when they need it. Again, as you need the data, you can better serve the patient at the time of service. Again, most of the transactions we support in real time. So even claim submission, you can submit a claim in real time. Not that it's adjudicated in real time, but you can submit the claim in real time. So we're looking at ensuring that providers have that access to the data. Again, it aligns the requirements for use of the core connectivity rule that we also published a couple years ago. This ensures that the systems are available and ready to go with the new connectivity using API-driven technology as well. So a quick update on the extensive changes that we made and the new updates to our existing rules as well as our new rules for attachments. With that, I'll hand the call over to Adam to talk about our next steps as we move towards our other activities. Adam?
Thank you very much, Bob. I'd like to provide a high-level overview of the core certification program along with the measurement opportunities offered to organizations pursuing certification on any of the operating rule sets. And so as we dive into the next slide, so as operating rules are published, CAQH Core offers a certification and testing program to ensure that the industry has successfully implemented operating rules and the associated standards as defined, required by regulations or trading partner agreements. Looking back in 2007, CORE launched the CORE certification to support organizations implementing those operating rules. The certification program validates and demonstrates conformance to the rules that organizations implemented to ensure that their systems are up to date. This program was developed by the industry for the industry through a transparent and multi-stakeholder process, similar to the process in which the operating rules themselves were developed. Core certification also offers cost savings, industry recognition, and a market advantage for organizations like health plans, vendors, and providers, or any organization that exchanges healthcare information. That certification program is also designed to ensure that those IT systems and products are aligned with federally recognized and industry-developed operating rules and underlying standards. So at the bottom of the slide, as you see to date, we have awarded 401 certifications, and provided on the slide are several of the organizations that have achieved core certification and recertification for the year of 2022. So looking at the next slide, one of the primary reasons as to why an organization chooses to pursue certification or recertification for that matter is really to ensure the conformance to federal mandates, ensuring that organizations have implemented the standards and operating rules as they were designed. Core certification is a good way to prepare for compliance reviews, and that CMS has been actively engaged in auditing organizations as part of their compliance review program. The certification seal reduces time to complete audit reviews such as these. Also, one of the other things I'd like to highlight on the slide is the core certification is positioned to help organizations assess, demonstrate, document, and certify conformance with federally mandated standards and operating rules. This works to build confidence for organizations in the event of audits. Speaking of conformance, on the next slide, we see that recertification is a very important component to the certification program that ensures There is an ongoing conformance to the operating rules over time as technology evolves and market conditions change. This is important, especially as operating rule compliance is being enforced by the federal government and certification being required for health plan contracts. A key enhancement that CAQH has recently made to the certification program in 2020 was adding in requirements for recertification. We believe that with evolving technology, mergers and acquisitions, and system upgrades, there is a need to assess ongoing conformance with the operating rules to maintain that program integrity. Further, recertification enables organizations to align with their healthcare needs for operating rules when those rule requirements are updated over time. In terms of timelines, core certified entities will be required to recertify every 3 years. These renewals may occur at any time during the calendar year based off of the initial year of core certification. After communicating an intent to recertify, recertification testing must be completed within 180 days. If there is a lapse in renewing the certification, CAQH Core will proceed with engaging an organization in the decertification process. Any updates to the CAQH Core operating rules will be incorporated within the certification process, and at a minimum, entities must implement versions of the operating rules that have been published 24 months prior to the core certification seal renewal date. Meaning, as organizations approach the recertification dates, they must consider and evaluate if they will need to implement new or updated operating rule requirements in order to recertify. Certification is now required. So if your organization was issued an initial certification prior to 2016, you must recertify by the end of this year to keep your certification active. So if you are a core certified organization, feel free to contact us if you are unsure on whether or not you need to recertify. So looking at the next slide here, one of the other components was the core certification measurement. So as the industry implements operating rules and standards, the need to measure impact is critical to understand the ROI and overall success. Currently, via core certification, core tracks the number of covered lives that benefit from the administrative efficiencies afforded by the operating rules and underlying standards. These results are more so published in an annual core certification progress report that captures the market reach and impact of the core operating rules and on the healthcare system. Measurement is a way to further enhance the value of core certification as well. Core will embed the collection of efficiency metrics into the core certification process to support organizations in measuring the impact of their operating rule implementations. The goal of this effort is to support priorities to track and articulate the impact operating rules have on operational and workflow improvements. As an optional benefit, core certified organizations will be provided with a few opportunities to receive benchmark reports, which would allow organizations to compare their progress to other organizations and the overall industry as a whole. And another benefit here is that an opportunity to engage in one-on-one case studies with core that further measure the impact of operating rules and standards on efficiency metrics and staff experience. On that note, I'll hand the call over to Mariana. Thank you.
Thanks, Adam. I'll now transition to CAQH Core's ROI and Measurement Initiative. In 2009, CAQH Core developed its ROI and Measurement Initiative to use real-world testing and observation to measure and track the impact of existing and potentially new operating rules. All of the pilot projects aim to confirm if adoption of core requirements supports automation, adds value to existing and emerging standards or technology, and ultimately reduces administrative burden for providers and health plans. To achieve this vision, each pilot project will have 4 primary goals. The first is to work in conjunction with industry standards, whether it's existing or emerging, such as X12 or FHIR. Additionally, each pilot will identify opportunities to refine or enhance existing operating rules and potentially develop additional rule requirements if needed. They'll also measure the impact operating rules have for automation when implemented with standards and observe through efficiency metrics identified with pilot partners. Lastly, the pilot projects provide additional quantitative data and shed light on the value of operating rule requirements when recommending rules to HHS for potential national implementation. For 2022, building off the recently approved and published attachments operating rules, which Bob went over earlier, the focus will be to pilot some of these requirements, as well as potential opportunities in the value-based payment space. On this next slide, I'll go over the approach for developing pilots. It's made up of 4 distinct stages. First, it's a detailed planning stage, then engaging with industry partners, executing the pilots or data collection, and finally, analyzing and reporting the results of the pilot to industry. So during this first planning stage, a scope and vision for the pilot is developed, where we define criteria for participants, including testing options, whether you would like to test new or existing operating rules. Then a conceptual model is also created so that we can visually display for partners the different components of a workflow available for testing and how the various standards, technologies, or rule requirements are mapped to that workflow. After the planning stage, we go into engaging with potential pilot partners, which includes meeting with them to gauge opportunities for collaboration. Together, the matched organizations elect which components and, if applicable, any subcomponents they would like to test based on their capabilities or interests. Staffing is also determined at this stage, including the role of an executive sponsor by the partner organizations. Finally, the fun part, after the teams align on the specifics around collaboration, we get to design the pilot and start to choose deployment environments, whether it will be testing or real-world production, specify like the data collection timeframes to make sure that substantive volumes or interactions are there to be able to draw conclusions, and measure the success or efficiency metrics like overall time for adjudication and measurement method, whether it be pre, post, or cross-sectional. The pilot can test each of the established metrics. And then lastly, the metrics and data are assessed and the results are reported out for industry education, whether that's through a webinar, conferences, or official publications like Industry Brief. Internally here on CORE, based on pilot findings, we'll consider whether we need to convene industry to make any adjustments to any rule requirements that may be a better fit to fit industry need. On slide 27, I can go over a successful example of a pilot that CAQH Core conducted. We recently finished a pilot effort with Cleveland Clinic and Prior Auth Now that focused on real-time exchange of data to accelerate prior authorization adjudication using HIPAA standards, core operating rules, and APIs. What we overwhelmingly observed in the results was that the combined use of technology, HIPAA standards, core operating rules, and emergent and APIs significantly accelerated the prior authorization adjudication process, which ultimately resulted in timelier delivery of patient care. From those efficiency metrics that we observed, there were some key findings. So through automation, which we defined as the use of standards, operating rules, and emerging technology, the overall turnaround time for prior authorizations was 6.7 days less using automation than when conducted manually. Additionally, authorizations that were fully adjudicated, meaning there was no staff interaction needed, it was completely automated, 25% of those authorizations were able to be conducted. And similarly, prior authorizations with interaction only needed upon initial submission, that's what we define as first pass, was adjudicated 7.9 days faster when using standards, operating rules, and technology. And all of these were also approved. For prior authorizations pending for additional clinical information, when they were conducted through the automated process, they were on average adjudicated 4.3 days faster. We also saw a decrease in volume of pens because of that better and more robust data that was submitted initially. Lastly, for peer-to-peer, which is often the most cumbersome, timeliest to process, when using automation, the requests were adjudicated 11 days faster, which is really substantive to see. The pilot was a successful real-world example of how efficiency metrics can be measured and assessed to understand the impacts of operating rules, standards, and emerging technology on administrative healthcare workflows and patient care. Next, I'll pass it to Caitlin to go over what CORE is doing in the AEOB space.
Thanks, Mariana. And now we'll go over our price transparency efforts. Next slide. Thank you. Following the signing of the Consolidated Appropriations Act in 2021 and the creation of the No Surprises Act, CAQH CORE launched the Advanced EOB Advisory Group to engage stakeholders in discussions on how industry can implement standard approaches to meet the requirements effectively and efficiently. The advisory group's discussions focused on approaches to facilitate the exchange of good faith estimates between providers and payers. The recommendations were published in a guidance document that illustrates how industry can meet the requirements leveraging uniform frameworks and industry standards. The group, which contained over 60 participants representing over 30 diverse healthcare organizations, used a consensus-based approach to ensure alignment across industry. The guidance document outlines recommendations for connectivity protocols, including CAQH core connectivity and HL7 FHIR APIs, messaging standards, including X12, 837 professional and institutional predetermination transactions, and HL7 FHIR, and related data content for indicator, patient, provider or facility, and service data groups. CAQH CORE is continuing its work to identify opportunities and develop guidance to support industry implementation of the advanced EOB provider to payer requirements. This year, we plan to convene a series of focus groups with participating organizations to gain insights, identify barriers, understand industry progress, and consider opportunities to support implementation of the No Surprises Act requirements, understanding that additional regulatory guidance is anticipated. CAQH CORE will hold an industry webinar following each focus group to share insights from the discussions, including implementation status of regulatory requirements, guidance on best practices, and approaches to overcome key barriers. Next slide. The inaugural CAQH CORE Advanced EOB Readiness Focus Group will concentrate on regulatory landscape and industry progress. The meeting will be a mix of discussion and poll questions focusing on policy updates, including the most recent FAQs published by CMS, industry progress to better understand provider perspectives on the types of use cases being prioritized, and to learn health plan strategies for implementing health plan to member and health plan to provider delivery of advanced EOBs, messaging standards organizations are considering implementing, current gaps not currently addressed by existing standards or standards development efforts, and future focus areas that CAQH CORE should be addressing or promoting as part of next steps. This focus group will meet this Thursday, May 19th. If you have not signed up for the focus group but would like to participate, please reach out to us at core@caqh.org and we will add you to the roster. Next, we'll hear from Erin Weber on next steps.
Thanks, Caitlin. And certainly we'll be sharing some of the findings of that focus group at our next town hall meeting as well, and on upcoming webinars. I just wanted to touch on a few things before we open it up for questions. One is just to highlight that there has been some federal activity in our space as of late. The National Committee on Vital and Health Statistics recently sent a letter, I believe at the end of March, to the Secretary of HHS with some recommendations related to modernizing aspects of HIPAA and other health IT standards to improve patient care and achieve burden reduction. And in that letter, they had 4 recommendations related to prior authorization and attachment standards, as well as improving processes and ways to create more flexibility around the regulatory process. So would encourage you to go to NCVHS's website for more information. Also, I know Caitlin mentioned some of the advanced EOB work and the No Surprises Act, and CMS did put out a set of FAQs last month as well on this topic if you're seeking more information there. From a CAQH core perspective, I just want to highlight some of our upcoming activity for 2022. Our board has reviewed the new and updated operating rules and will shortly be sending a package of rules to NCVHS for consideration for a federal mandate under HIPAA that includes some of these new rules that Bob just reviewed and the updates, as well as an updated connectivity rule. So stay tuned for more information on that shortly. We are also working with our testing vendor to build out our testing sites to support core certification for the attachment rules and other new and updated operating rules. So as you're thinking through your priorities for the next year, please reach out to us and we can talk through the process for certification. Mariana shared with you all some of the great work we're doing with our pilot and measurement initiatives. This year, we are looking at supporting a number of areas within this, including value-based payment pilot related to the use of CPT2 codes. We are looking for organizations interested in participating in an attachments pilot, implementing the new operating rules and measuring their impact, particularly those organizations that are already using electronic attachments, and again, our core certification measurement efforts as well. So we look forward to sharing all of that data with you over the next year. And finally, this is really a learning year for us. You saw that we did a lot of rule development work last year, and we thank our participating organizations for their time and commitment. It is no small effort to develop a set of operating rules, and as I mentioned earlier, the input from and guidance from our participating organizations is essential. This year, we're going to spend a lot of time researching new opportunity areas and areas where we've heard from our participants and the industry that operating rules could be useful, including value-based payments, healthcare claims, as well as looking at some of the challenges related to practice management system and EHR data exchange. So if these are areas of interest for your organization, I would encourage you to reach out to us at core@caqh.org. We may be reaching out to you too for a conversation, for learning and information sharing. And so we look forward to touching on a number of topics over the next year. I'll now turn it back to, I believe, Daphne for a polling question.
Thanks, Erin, and that's all a perfect introduction to our polling question. So I'll go ahead and launch it on the screen here. Please select all that apply. Which of the following topic areas would your organization be interested in participating in? So we have EHR, or Practice Management System Integration, environmental scan, an environmental scan on VBP, ongoing opportunity area research around healthcare claims data content, and finally, a pilot and measurement study on attachments. All right, I'll let that go for a few more seconds. Thanks, everyone. So now it's time for our Q&A. If you have any questions that you would like our staff to answer, please submit it in the questions panel on the right of your screen. So I'll kick things off with a question for Erin. Going forward, how does CAQH Core plan to evaluate existing operating role requirements to ensure that they respond to industry needs? Will there be an annual review in place?
Good question. So CAQH Core already has an annual process where we work with our participating organizations. Usually around the August timeframe, we put out an annual survey where we ask our participating organizations what areas we should be prioritizing for the upcoming year from both a rule development and mandate perspective. And then our board, which is representative of plans, providers, vendors, as well as a number of industry advisors, also helps prioritize and evaluate the focus for each coming year. So it's really a mix of participant input and board input, as well as input through webinars such as these when we hear from you all about your priorities within the industry.
As a follow-up, is there any plan in place to address opportunity areas that came up during the eligibility and benefits update?
I'm not sure I totally understand the question. So Bob described the updates to the eligibility data content rule as well as the eligibility infrastructure rule. And what I can say is those updates are going to be included in the package of rules that the board has approved to send to NCBHS later this month.
And speaking of NCBHS, I'll lump these two next questions together for you. What is the anticipated path and time frame for these operating rules to be mandated? And when will covered entities be required to be in compliance? 24 months after the mandate or 24 months after the published date of the rules?
Good question. So there is a formal process. Once operating rules are approved through the CAQH core process and by our board, they are available for industry implementation and core certification. So organizations can begin implementing these operating rules as part of their good business practices at any point. The federal process begins when the CAQH core board submits a letter of recommended operating rules to the National Committee on Vital and Health Statistics. That letter triggers a process at NCBHS where they review the operating rules. The committee does. They invite feedback from industry, either through comment letters or a hearing where they get more broad perspectives on the proposed operating rules. And then NCBHS will then make a recommendation to the Secretary of HHS whether or not to move the rules forward for federal mandate. NCBHS could choose to split the rules, only move forward the updates to the currently mandated rules, move together the whole package with the new rules as well. And once HHS receives that recommendation, then if there is a recommendation to move the rules towards federal mandate, HHS would then put out an interim final rule for comment where industry would have the opportunity to comment. And ultimately, once they put out a final rule, then industry typically has 25 months to implement. So that whole the NCBHS, HHS process before a final rule comes out typically takes 1 to 2 years. So add that plus the 25 months and you can get an estimated timeline should the rules be federally mandated, how long your organization might have to implement them.
Thanks, Erin. A few clarifying questions for Bob on the new rules. So during the prior authorization slide, you mentioned that if a service or procedure requires prior auth, the health plan must communicate if that service is turned on. Can you clarify what you meant by if that service is turned on?
Oh yeah, apologies for any confusion. Basically, the eligibility transaction, the 270-271-X12 transaction, it has an indicator within it that when the response comes back from the health plan, that indicator can be turned on if that particular STC code or procedure code or diagnosis code, the original one that came in on the inquiry, when it goes back out from the health plan, it can say yes, no, or unclear or unknown. That code, again, STC code, requires a prior authorization or not. Today, that field is left up to the health plan to complete that or not. The operating rules turns that on as a required field. Health plans must indicate whether that particular STC code or procedure code it has a requirement for PA. So you have to use the yes, no, or unsure indicator. Today, it's only at the option of the health plan. Tomorrow, with the operating rules, health plans will be required to return that indicator. So that's what I meant by using that indicator.
Thanks, Bob. So on the eligibility and benefit front, will entities have to respond to an eligibility benefit request on STCs or procedure codes? Is there a mandatory list of procedure codes, or would the requirement be applicable to all procedure codes?
Another good question, and thanks for the clarity. I think what would be helpful here, there are a set of requirements for the core rules on STC codes. Today, or I'm going to say yesterday, we had 51 codes that were required to be supported by health plans and available for providers to use for an explicit inquiry. So if a provider submitted the inquiry with one of these codes, the health plan is required to send benefits specific to that explicit inquiry. In the future, with the new codes added, and there are those several, almost over 178 STC codes now, with those coming in, again, these are almost all explicit STC codes for explicit specialty services for particular members. Those codes must be returned now with the new sets of operating rules requirement. Health plans will have to support 178 explicit STC codes, not just 51. So those become really important. Now, there are a large number of discretionary codes, and discretionary, we define that as codes that might have a uniqueness about them, perhaps their mental health or women's healthcare delivery. Those are certain codes that will be the health plan's discretion to send back, because they might be like protected services. So more information in the rules about what we mean by that, but those codes are really important because you'll have to be required, health plans will be required to support these whole nother set of explicit STC codes to return benefits on for those specialty services. And there are, with the rules, a host set of codes included for HCPC, these diagnosis procedure codes, CPT codes, HCPC codes. If they fall within the category of physical therapy, occupational therapy, surgery, and imaging, health plans are required to support CPTs and HCPC codes at that level for those categories of service. Just those, just physical therapy, occupational therapy, surgery, imaging. So if any of those codes fall within those categories of service, then health plans will be required to support an eligibility inquiry for those sets of codes. Again, that's in our new rule set.
Thanks, Bob. And we are coming up on the end of our hour here together, and I do want to highlight some of our upcoming core education sessions. I'll post the link in the chat right now where you can register for any of the 3 webinars that we'll have over the next couple of months, as well as register for the WEDI Spring Conference, during which we will present an overview of core and our ongoing initiatives. Finally, I want to thank you all for joining us, and all of our great speakers for giving us all these updates on what we're doing. If you have any questions, please feel free to email us or visit our website. Thanks again. Have a great afternoon, everyone.
Thanks, Daphne.